I'm fortunate enough to have been one of the original principal investigators in the trial. So I have been doing TOPS now for 7 years, I think since 2018 or 2019, 6 years maybe. And the advantage of that, although it was a FDA trial setting and less of a quote unquote real world setting, I do have patients with 5 and 6 years of follow-up. And it's really, really nice to be able to have that and see that. And I believe for a variety of reasons, I think I've done more TOPS cases now than anyone else in the country. I don't work for Premia, not getting any kickback from Premia. It's not the goal. The goal is really doing the right surgery for the right people. And the results really do speak for themselves. Not only do the FDA clinical trial results show significant benefit compared to fusion, some of the new data that's coming out is actually showing superiority of fusion. And for people who have any statistics background, one of the most important things in statistical trials, which is really sets the bar low, personally, if you ask me, is proving non-inferiority. When a new device or a new technology comes to the market, the goal is to show that it's as good and it's not worse than what's already available. And that's, for whatever reason, has been the standard for decades. And the fact that we have new data coming out that's showing superiority is a much higher statistical milestone to achieve. And so that's exciting. And in general, my practice is really focused on both brain and spine surgery. I do brain tumors and a lot of trigeminal neuralgia and facial pain, but a good 70% of what we do is certainly spine. And while the days of scoliosis surgery are not gone, and long construct fusions are not gone, I really do focus almost all of our research efforts on motion preservation. And we are known, my partner and I, Dr. Vokcher and I are, I think, known more and more for really pushing the envelope under the auspices of trials or doing ethical clinical research. We truly are trying to push the envelope forward. The FDA says you can do 2 cervical discs, and we routinely have done 3 and 4 in hybrid constructs, mixing, matching fusions. The goal is to use the technology that's been tested in the best possible way to improve your quality of life and do it in the most physiologically natural way. I have an old mentor of mine said, and it's a really important message in surgery: you want to go in and you want to leave with as little disruption to the anatomy as possible. And I think that that's a very important lesson. And when we talk about minimally invasive surgery, people think, oh, I do endoscopic surgery also. Small little fingernail incision with a Band-Aid, no sutures. But part of the lesson in minimally invasive surgery and minimally disruptive surgery is doing something physiologic. And that's why so much of my research and so much of my work, and my partner and I do a lot of this together. I collaborate with a lot of my mentors. Todd Lamb, Pat Johnson are mentors of mine, and we do work together all the time, looking to always improve a patient's quality of life so that they're highly functional, not just Band-Aid solutions, but doing so in a manner that is minimally disruptive, not just minimally invasive. And the disruption part is what I focus on, because motion preservation, in my opinion, is minimally disruptive because it's natural and physiologic, as opposed to fusion, which is not. And it is counterintuitive to everything we're trying to do. And I say this a lot when I talk to people, but if you said 40 years ago that or 50 years ago, we're going to put in an artificial hip or an artificial knee, that wasn't even available. People fused the joints. But today, if you fuse a knee or you fuse a hip, that's heresy. We have artificial mobile implants that are designed to work naturally as a substitute, as a replacement for a diseased process. And so that's what I strive for. And I will push the envelope in an ethical, clinically, statistically sound way. I have a background in clinical research. I was in Boston at Harvard for many years, and we focused on clinical research and doing things properly. The goal is to improve pathophysiology, improve a problem with a solution that makes physiologic and biomechanic sense. And that's why I'm such a strong believer and the highest user, I think, of TOPS in the country, because of that. That's why we're doing the ADR TOPS trial, because of that. We don't want to limit options to patients and always resort to fusion. Fusion, in my mind, unless there is gross instability, fusion, in my mind, should be a backup option, not a primary option, and certainly not the standard of care. Jeff, do we have any questions yet?
Yes, we do. We have a couple.
Okay, let's do it.
Okay, so first question is, what's the average length of time for the procedure?
Great question. So, um, tops right now, we're really using it only at one level. It's only designed for one level. So if we're talking about just a one level surgery, because there are ways to combine old fusions to the tops, but just a virgin one level top surgery, it's around 2 hours. I've had some cases go very smoothly, hour and 40 minutes, others that are a little bit more challenging based on the anatomy, 2.5 hours, 2 hours 40. But in general, my cases for tops are lasting around 2 hours.
Then the follow-up to that question would be recovery time,
Yeah,
tops versus fusion.
sure. Um, so we also, not only I think am I the highest user, but I think we are the only group that is just about to publish a large data set of outpatient tops. So we actually do this as an outpatient, which is not routine over the world. And because we do it as an outpatient, I get a lot of feedback from my patients directly. And most of my patients, a lot of them doctors, nurses, very busy CEOs and professionals, will tell me they hate me for a good 4 to 5 days. They're not really that happy because they're uncomfortable. It's not that they're in agony and they can't get through it. It's that the back muscles don't like being disrupted. So the initial recovery is the same. I mean, fusion tops, the surgical approach is very similar. So the spasms in the back really bother people when it comes to changing positions and moving in and out of bed or in and out of seated position. But when people get up and start walking, they feel a lot better compared to their preoperative symptoms almost immediately. They always tell me, oh, they went for a mile hike post-op day 3, post-op day 4. And so that's really, really reassuring. But it certainly is a procedure that requires some recovery, just from a normal surgical approach. What is fascinating, however, is if you look at the trajectory in terms of healing from patients with TOPS versus fusion, a fusion, the data, and this is variable depending on patient's age, bone density, medications, hormones, but in general, fusions take a good 6 to 12 months to heal. In terms of for a fusion to mature, to quote unquote fuse. And what we've shown actually, and what we've done for most of our patients, is we've had TOPS patients who are back engaging in pretty high level activity by about 4 to 6 weeks. I've had golfers and athletes that are practicing and training by 3 months. I've had patients doing high impact stuff like skiing within 6 months of surgery.
Great answer. Thank you.
Of course.
Um, Another question says, hello, I'm a 72-year-old female. I'm pretty healthy, diagnosed with multi-level spondy. Am I the right candidate for TOPS?
Hello, nice to meet you. The answer is, maybe. It's very hard to just kind of conjecture. I do a lot of virtual. I think about 70 or 80% of my patients are out of state or international. And so we do a lot of virtual consultations like this, but I will have access to your images, to a lot of your studies, and I take that all into account. TOPS could be the right solution for you at one of the levels. The question is, what about your multi-level spondy that you're describing is causing symptoms, and do you need to have treatment at more than one level? Because TOPS really can only be done at one level. And so the question is there a hybrid scenario that would be required if we felt the other levels were symptomatic? And I think this is a very important point. I'm a big, big believer in treating the patient, not the picture. Too much of what we do is picture driven, radiograph driven. And I think that's a very, very dangerous precedent to set. You don't need the picture to look perfect. You don't need it to be on Instagram. You need to treat the patient's symptoms. And so with that said, a lot of what we do in neurosurgery is mechanical and understanding the anatomy. And so when there is a radiographic problem that explains a patient's clinical presentation and there's a match, that's when we have the best chances of surgical result, and a positive outcome. So the answer is maybe. You could be a candidate for TOPS, could be a candidate for hybrid or not. And so I'd be happy to evaluate you and give you more information.
Great. Next question is, how do you incorporate S1 into a TOPS device?
So I've done, and Ron, who I saw log on, who's the CEO, could correct me if I'm wrong, but I believe I've done more L5S1 TOPS than just about anyone in the country, if not the world. It is considered off-label, so it wasn't tested in the original FDA trials. But we have now done it many times with great success. It is certainly not something the company is going to talk about because they're not allowed, and nor should they be promoting any off-label use. It is, but the FDA on their website, it's very clear medical legally that physicians, surgeons can use FDA-approved devices off-label if they see fit and it seems appropriate. Half of the more than half, 90% of the medications that are prescribed today are prescribed off-label, not for the original indication that they were actually approved for. So to answer your question, is it possible? Yes. Is the data more limited than, say, what was done in the last 6, 7 years with the FDA trial that I was a part of? Certainly, because we didn't include those patients in the trial. But I've been doing it for the last 2 years, and we haven't had any abject failures. We certainly don't have the same number of patients, and it certainly can be considered. It just is a case-by-case basis, and I would have to evaluate you further to make sure that I thought it was appropriate.
Makes sense. I'm a 70-year-old male with an L5 PARS defect. Am I a candidate for TOPS?
So it depends on if that PARS defect is causing you symptoms. I mean, it's a radiographic finding. Is it unilateral, bilateral, one side or both sides? Is the PARS defect creating a hypertrophied arthritic joint causing stenosis? There's a lot of considerations. Again, on-label, off-label use. I have done many cases of TOPS for lytic spondies, PARS defects, fractures. It's an extremely robust device. It's not as tested in those situations. And I will tell you, this is kind of a good segue, but Jeff and I were talking a little bit earlier. When asking about candidacy for TOPS, are you a candidate because you have a PARS defect? The answer could be yes, but one of the important factors to look at is, and everyone's actually asked great questions about the posterior elements because we're talking about the back side, right? That's where this is the TOPS device that can move, but you're talking about the back side, the posterior elements where the facets, the PARS, everything is located. In order for the TOPS to function normally, it has only ever been tested and utilized when you have a relatively viable symmetric disk space. And so as the TOPS moves, it's relying on that disk space. And so a lot of questions have come up lately with patients who are saying, well, I want to get, second, third, fourth opinions. And, someone said a fusion, someone said they could do the TOPS. I said, a surgeon who has average to above average skill can do it. The question is, do we have data and does it make sense from a bioengineering and biomechanical standpoint? And Jeff, correct me if I'm wrong, but according to the engineers who designed the device, who worked with the device, the recommendation is to not use the TOPS when you have asymmetric disc disease, asymmetric disc collapse, because we do want a more symmetric, more robust. The data is greater than 4, but it arguably should be a little bit more millimeters of disc space throughout. And so are you a candidate with a PARS defect? The answer is maybe, but I would also want to look at that disc. And Jeff, would you agree that the engineers are saying the same thing that I'm saying?
Oh, absolutely. It just hasn't been studied, and that's not what we would determine as a best candidate for the
Right.
device. I mean, exactly what you're saying. I mean, what really helps the device is to work in conjunction with a healthy disc.
Right.
Um,
Right.
and so you're absolutely correct. So that's not something we've studied, not indicated as far as the FDA approval goes. And so something that we would advise against.
Yeah, and I've seen a lot of patients have asked me. I mean, in the trial, the original trial, we were allowed to go up to 10 degrees of quote unquote rotational scoliosis. And what happens is it's not the 5 degrees or 8 degrees, 10 degrees, or even off-label 15 degrees of scoliosis that bothers me so much. What bothers me is that when you have scoliosis and you have a rotational deformity or you have anything like the curvature deformity, you will then get asymmetric disc disease. That is what bothers me because that is what causes the tops to behave less predictably, in my opinion. So that's what we need to look for when we're talking, we do these webinars for other surgeons and other physicians. And we need to make sure that we want the tops to be successful in our patients. We want patients to have the best chances of success. So it has to be done in the right cases. And, again, this is not a Premia talk, but, the reason why we created the ADR tops trial and why we have several sites that are signing on, why we're really ramping up the trial is for cases where we want to preserve motion. We want to avoid fusion. We want to push the frontiers forward so that fusion is not the gold standard. But in cases where there's an asymmetric disc or no disc, and that we can try to restore that disc height and disc anatomy so the tops can work. So, and again, it's experimental and it's something we're working on, but it is certainly, in my mind, based on the studies we've looked at and based on the cadaver labs and the biomechanics, it's more predictable than a disc that's in contact and connecting or asymmetric.
Great. Here's one. I have bone on bone to my facet as well as spondylolisthesis L4, L5. Am I a candidate for TOPS?
Bone on bone facet. So I
Yeah,
mean,
that's what it says. I'm trying to process that. Yeah.
yeah, I'm not entirely sure what they mean by that. I mean, the facets are a synovial joint, and so you're technically bone on bone with a little bit of synovium. If you meant bone on bone in the disc space, then the answer would be no. You wouldn't be a candidate for TOPS alone necessarily, but you may be a candidate for our trial, where we restore disc height and then consider the TOPS. But again, these are very nuanced questions, and I love them, but it would require a one-on-one chat, can be via Zoom. I would need to look at your images, potentially would order different images and different views, and then we would come to a conclusion that made the safest sense and the biomechanic sense of giving you the best chances of longevity. Because when we do these surgeries, TOPS, artificial disc, the trial, the goal isn't band-aids. The goal isn't to just deal with a problem and say, okay, goodbye. The goal is for people to use their backs, to enjoy their lives. And there's nothing that I love more than getting a patient text or a call or a post or something that says, I just played around an entire round of golf and I've never felt better. Thank you. Or I just traveled with my spouse across the world and we were on a cruise and we did the day trips in different cities and I could walk for miles. Thank you. I just skied. I had one patient. I just skied 78 days last year. I'm like, I don't know what you do for a living, but I would love to ski 78 days a year because I have a hard time getting my kids to go 20 days a year. But I mean, though, that's why we do this. And so I am very, very, very keen on optimizing results for patients, and I'm very careful about who we select.
Um, Another nuanced question. Does the
Sure.
presence of a cyst cause complications or rule out the procedure?
Of a facet cyst? I would
Yeah, it
assume
just
that they're
says
asking.
cyst. I'm assuming facet cyst. Yes.
No, not at all. It actually is a great indication because we remove it, right? So the facet cyst can certainly be symptomatic in patients. And so it's a great indication because if that is the source, I mean, and that's part of what the discussions would be, and that would be part of the assessment. But if part of the reason a patient's having symptoms, um, absolutely. I mean, that's a great reason. Great reason.
How about a layup question? Not so nuanced. Um, can I have top surgery for spondylolisthesis at L4, L5?
Yes. If again, if you're a good candidate, absolutely.
um, and let's see, there's a couple of questions in here around being previously fused. And so that once again, we're going to be a little nuanced here. Um, so I think one of these is asking about adjacent level, Jared. So um, you could speak to if I've been diagnosed with adjacent level disease to a previous fusion. Could you speak to that?
Sure. So, if you've had a previous fusion and you have adjacent segment disease, which unfortunately is all too common, you certainly could be a candidate. It depends on the reason that, again, you're symptomatic, the type of adjacent segment disease, the disc space anatomy, but certainly we have approved ways of actually connecting the tops to an adjacent segment fusion and them working together in kind of a hybrid scenario. And that's been done many times with success. Absolutely.
Good. Um, Here's one: is TOPS an outpatient surgery? Um, Also, the additional question is it an open surgery, or and how long are you hospitalized?
Sure. So we have done many tops outpatient. And we have a wonderful team that helps make that possible. And we have visiting nurses, and we have patients travel from all over, and they can go to an aftercare. Some of our patients really do like this kind of bougie aftercare in Beverly Hills where they're taken care of for a day or two. Some patients go to a hotel, and we have nurses visit. We're very hands-on. A lot of people don't want to be in the hospital. Some people do stay in the hospital a night or two. But it's certainly, when we are about to actually publish this data, it certainly can be done safely and effectively as an outpatient. With that said, I think there's been some late add-ons here for people joining the webinar, but the initial conversation around the recovery was a lot of my patients love me but hate me for 4 or 5 days because it hurts no matter where you are, because the muscles are in spasm from any back surgery. It's not unique to TOPS. And so, but we're really good at getting patients up, we're really good at blocking those pathways and starting the rehabilitation very early, because the trajectories are 3 or 4 weeks, in the gym doing light exercises, 6 weeks active exercises. It's pretty remarkable.
Okay. How about what to expect from PT post surgery?
Yeah, that's a great question. PT is something I utilize often, not always. Depends on patient's needs, depends on how the surgery went, and it also depends on what their condition was coming into surgery. And that's an important consideration. So PT's initial plan for almost all my patients is just including exercises for core strengthening after surgery and range of motion, because you want to use the device. Okay, so I can't stress that enough. It's not a fusion. A fusion, we put people in braces, we keep them straight, we say no bending, no twisting, no lifting, the BLT, bending, lifting, twisting, no BLT for prolonged periods. It's actually the opposite. With my TOPS patients, there's no brace, and I want you doing very early ranging so that the musculature can relax. And so it's like a bad pull in a gym type exercise that you can stretch out and work out. So that's kind of the first initial PT. And then after that, they do more aggressive strength training, resistance training exercises.
A couple of follow-up questions to hospital, well, whether it's outpatient or not, and I think it's more around insurance and Medicare. So I would say, yes, it's approved by Medicare. We have a lot of success with Medicare for people online. Um, Insurance is dependent. Your insurance may require that requires an outpatient. I mean, that it's an inpatient procedure. Medicare does require it's an inpatient procedure. So it
Yeah,
will be insurance dependent, correct?
Yeah,
Yeah.
Medicare and insurance are complicated right now. Private payers really have not unanimously signed on, but that doesn't surprise me. It took them years to even approve artificial discs, long after FDA approval, but it will come. It's unfortunate, but it will certainly come because the data speaks for itself. And Medicare will cover it as an inpatient. The problem is that most hospitals still don't. So just because Medicare will pay for it doesn't mean that the hospital will allow it in their doors. So it's a little bit of a negotiation. The honest truth is most of my patients are paying out of pocket currently, but we are always working on ways to try to help, and we're constantly fighting the healthcare system to help with reimbursement. So the more data that we collect, the more the work that we do, the more we hope to push that forward.
So this one is interesting. And can you? And we only have about 3 minutes, so we are going to need to move through some of these
Sure.
questions. So you've got here's a good question, and you have a friend online who I'm sure would like to hear the answer to this question. But I have L2, L3, and L4, L5 spondy, and L2, L3, L3, L4 stenosis, and I've been recommended. Well, am I a candidate? So I'm going to say that
Yeah, I
again.
mean, no, it's okay. The answer is, again, maybe. I mean, we can only do tops at one level. But we can create hybrids. So I have done many cases with artificial discs at multiple levels and tops at one level from behind, artificial disc in front. I've done many situations where we've had fusions down below and tops, in certain areas. It really depends on the case. So you certainly could be a candidate if you have multi-level disease, and we believe that it's multi-level symptomatic, that we would consider a hybrid. And there's actually, not on tops, but there's great data all over Europe showing that motion preservation is better than fusion. But if you have to have a hybrid construct, meaning part fusion, part motion, is still better than long construct multi-level fusion. And so that's why we push it so far. And I did see another question about uh from my partner who's logged on, which is funny, about anytime soon are we getting multi-level tops?
Yeah.
I'm not at liberty to discuss. We not yet, not anytime soon. And then I saw a question also come up about MODIS around the world. So MODIS is not FDA approved yet. Was a trial where we did artificial disc replacement that also removed the posterior elements because MODIS was the only artificial disc that you could place from behind. We've had good results with MODIS in trial. The only issue I have with MODIS is that it's a metal on metal implant. It's two implants that go in that are supposed to work together, that doesn't always work perfectly. And it doesn't have any posterior architectural support. And so your only ligamentous structures that it relies on for hyperflexion or hyperextension injury is the ALL in front of the spine, right here, because it's the only thing that's not disrupted. Whereas there is really very little debate, and one of my mentors, Todd Lamon, who was big in the MODIS trial, he and I just did a hybrid MODIS tops together. MODIS was below, it caused adjacent segment disease. We did the tops above. He completely agrees with me that with respect to integrity and someone who's more active, the tops and an ADR tops combination is much more rigid and much stronger biomechanically than a MODIS alone. But a MODIS is a good motion preservation. From what we can tell, the data is still very early. It's not as mature as the TOPS data at all. It is a good option for people who can't get anterior surgery from just overall health reasons or scarring or repeat surgeries. And people are afraid of anterior surgeries, but we're really quite good at it these days, that the complication rate is like less than 1% almost with our vascular surgeons. But it is a good thing to consider and think about in terms of options. Can we bang out any more? We have another minute.
I think that's a great place to stop. We're
Great.
we're at the half hour. Dr. Ament, thank you for your time. It's been very informative. I hope everyone has their questions answered. If you have additional questions, please reach out to Premia Spine. I believe you guys have all that information. Um, or if you want more information about Dr. Ament, we can provide that information for you as well.
Yeah,
So
happy to talk to anyone also offline. Please reach out. You can reach out to my office, office@nsg-la.com. And I will answer questions. I can do a one-on-one Zoom. Lots of people reached out at Dr. Jared Ament on social media. I try my best to get back to everyone. So I think information, when you say informed consent, when we're talking about novel technologies and novel ideas, that's the most important. So having an avenue to communicate and bounce things off each other is really important. One word of caution: you ask 5 surgeons how to treat a problem, you get 6 answers. So sometimes the detail, the devil's in the details, right? It's really important to develop a relationship, trust the process, and I think a second opinion is great, third opinion at sometimes, 4, 5, 6 opinions, it's going to muddle the waters, and it's really hard for people to even know what to do or what's right. So what I can tell you, I'm busy, right? And I'm blessed, so I don't need more quote unquote business, but I want to help people, and I want to teach, and I want to do more. And so if I can be a resource, you don't need to come to me. But if I can help give people good information, candid advice, and set you on the right path, I'm happy just to do that as well.
Great. Thank you very much for your time, Dr. Ament. Thank you, everyone. And look forward to more invitations for more webinars in the future from Premia. Listen, everyone, have a great remainder of your day and have a great weekend. Take care.